CSEP and the New York State Ophthalmologic Society are honored to have David Park II, immediate past president and executive director of the AAO, to introduce the 2022 David Park Lecturer, David Chang. I want to mention also that David, as an example of his incredible humanitarianism and generosity, is going to give his honorarium of $1,000 for the David Park Lectureship to the ASCRS Foundation. David, thank you so much on behalf of all of us. And now I would like to introduce Dr. David Park II to introduce our David Park Lecturer for 2022. My pleasure to introduce David Park II.
An ophthalmologist, a retina surgeon, son of Connecticut, and currently the CEO of the Academy. And I really appreciate the opportunity today to say a few words before the lecture that remembers and honors my dad. You know, he was tremendously proud of being a citizen of the state of Connecticut. He was proud of his Connecticut ophthalmology colleagues, and he was proud of CSEP. My dad was very much a believer in ophthalmology organizations and in their ability to leverage the talents of individuals and be a force multiplier for good. And this was true whether it was the Department of Ophthalmology at Yale, CSEP, or the American Academy of Ophthalmology. He loved being involved in all of them, and it was really a wonderful thing to see that even though parts of his body failed him, he still had all his marbles, even into his late 90s. The opportunity today to have David Chang as the lecturer is particularly special for me, for my family, because when my dad developed cataracts, he said, I'd like to have surgery done out in California, near you, where you can take care of me. You tell me who it should be. Now we've got, as in Connecticut, lots of good cataract surgeons in the Bay Area, but David Chang was far and away, for me, the first choice. And it's not just because of his world-renowned scientific and technical expertise, the care he takes in delivering ophthalmic surgery, but it's really the relationship that he develops with his patients. When I went with my dad to David's office, it was absolutely palpable, and my dad commented on it. And during the better part of the last decade of his life, he had good vision out of that eye because of what David did and the care that David took of my dad. And I remember he came back to the house, and about a week after surgery, he was saying, oh my goodness, I can see the hands on that clock. I didn't even know you had a clock there. Well, we've all heard this so many times from patients, but when it happens in your own family, it really means something. And so I can't think of anything more fitting that through this lecture and having David Chang here today, it continues their connection even after my father's death. So David, thank you so much for being a part of CSEP and for delivering this lecture.
All right. Well, David, thank you so very much for that amazing introduction. And what an honor this is, as David the second said, what a privilege it was to meet David Park Sr. He was 93 at the time, sharp as a tack, and just a very charming and humble man, very interesting. And so this is especially meaningful for me. And when we talk about, contributions to our profession, we're usually talking about research, clinical, or teaching. But how many people can say we contributed a son and a grandson of this caliber to our profession? And I was struck by this quote of David Park Sr. that really kind of touches on, something that I think we can all learn from, both in respect to our own families and our relationships. And if I could just congratulate David II on ending his term as a remarkable CEO of the Academy, and ending it by getting us mostly through COVID in such with such great leadership. So as has been mentioned, when David Sr. retired, he actually did low vision and a lot of volunteer work, won the Humanitarian Service Award from the Academy in 2002. So I've chosen a topic for this talk. Basically, it's an opportunity for me to introduce the audience to what I consider the greatest team of cataract surgeons and the lessons I've learned, and I think that we can all learn from them. So I have no financial interest in any of the information here. So this was 17 years ago. And at the time I wrote that the greatest challenge we have in cataracts isn't really creating an accommodating IOL, it's the increasing backlog of cataract blindness. And the problem is intimidating for many reasons. We have limited surgeons. So how do you get them to be productive? They have to be doing high volume, rapid surgery to really gain scale. But they're dealing with cataracts that we don't here in the US, the most advanced, and complications like a dropped nucleus are blinding there when you don't have vitreoretinal surgeons around the corner. And then you have to somehow make all of this cost effective in terms of the equipment and the supplies. Dr. Venkataswamy passed away basically a year later. But he is basically at the heart of Aravind, and it's the Aravind Institution that has actually solved that problem and shown us how to do it. So when he retired from his academic job, forced retirement at 58, mandatory, he founded a family clinic with the humble mission of curing needless blindness in southern India. It started as an 11-bed hospital, and he started it with loans from his family and involved his family members. And those that weren't physicians became administrators. And this is the Venkataswamy family tree. There's Dr. V. And to this day, these are all the sort of core of the Aravind institutions, which now number close to 14 different hospitals and surgery centers. And I've written on this in the past that there are lots of lessons that we can learn from low to middle income countries. And those are the 5 lessons I'll give you. So the first is that Aravind has perfected a model to eradicate cataract blindness. And their model has been replicated on different levels and a different scale throughout the world. When I started my relationship there was back when this hospital opened in 2003. I was invited to help inaugurate it with a lecture. And I met these 3 people who I've been collaborating with now for the last 19 years. And of course, I went there to teach phaco. But what I didn't expect was to be totally wowed by the way that they operate and the way that this is orchestrated and choreographed in a way that I just never thought was possible. So my friend, Dr. Venkatesh here, who is operating, I said, Venki, you know, this is something everybody in the US and in the West should be able to see. It's a long way to get here. What if you made a video and we could show it and just put on the inside what is happening in the operating room while you're showing the surgery. And this is the video that he created. So you'll see the timer here. And this is the manual small incision cataract surgery without phaco. It's a retrobulbar. You'll see it's sutureless with a temporal scleral pocket. And what you'll see in the inset is there are 2 parallel beds. And while he's operating on this exact patient, another team is going to bring in a second patient parallel to the first. And they're going to prep them and drape them and get everything ready. There'll be another scrub tech. And then in between, as soon as he's done with this case, he will go over to the other side. So this is an unedited video with a picture in picture. So you'll see that each of these cases is going to be done in less than 5 minutes. Now, with this kind of productivity, one surgeon, depending on how skilled they are, can do anywhere from 10 to 16 of these cases an hour. And they'll basically do 300 to 400 cases a day in this way. And these are all charitable patients. So where do they come from? Well, they do screenings at local villages, and they'll do those on Sunday. And Sunday evening, they bring everybody by bus to one of these regional hubs where they have their surgery on Monday. There you see the next patient is just laid down, is now being prepped for the surgery. So they keep their costs down by basically manufacturing everything in-house. It's called Oralab. They do the glasses, the IOLs, the sutures, the medications. Here you can see this is a funnel-shaped incision. So he's able to extract this manually, and you'll see that it's self-sealing. The PMMA IOL costs about $2, and the cost per case, excluding the labor and overhead, are basically $10 a case. So they reuse everything, the phaco tubing, the BSS, the gowns and gloves. They use what we would call short cycle sterilization, what some would used to call flash. And in publications such as this was 600 cases, which happens to be the 2-day volume of 3 surgeons, 90% of whom were legally blind, doing about 16 to 18 an hour. And they had excellent visual outcomes with long follow-up and a 1% PC rupture rate. So here you see he's still under 3 minutes, and he's just put in a 3-piece PMMA IOL. And because this is self-sealing, this will be sutureless with no induced astigmatism because of the temporal approach. This is another paper that we did comparing phaco to this technique on white cataracts, and it was comparable. And this was all basically the genius of Dr. V. And his inspiration of all things was McDonald's. There you see Dr. Venkatesh now has finished that case. He simply swivels over the microscope. He sits down and tackles this mature white cataract with a different OR team. And what impressed Dr. V about McDonald's is that they are so efficient and you get great value for your money. And they do that because everything is standardized. You can't get a custom hamburger. It's streamlined. Everybody does it the same, whether it's a McDonald's in Connecticut or one in California. So why couldn't we do this with eye surgery? It is almost a commodity here. And they currently do about 40% of their patients pay something. And then that subsidizes the care for the 60% who basically pay little to nothing. And so this is financially self-sustaining. They don't depend on philanthropy or government funds for the actual operating room. So here he's about a minute in, and you see he did use trypan blue dye here. Now their private patients are going to pay the going rate in India, which is about $150 to $300 US. And that generates enough surplus to cover the overhead and the cost of all this charitable care, 60%. And that also eventually led to the expansion of this small clinic into the current Madurai Hospital. They then, over time, opened up different regional centers and other places in southern India. And we're now 2003, this video is in the Pondicherry Center. So here you're going to see he's prolapsed this into the anterior chamber and he'll extract it. So they currently do the largest volume of cataract surgery in the world as a system of these 11 regional hospitals. And what's most important is they do an enormous amount of training. It's estimated that 1 in 6 cataract surgeons in India have been trained at Yerevan, but they will train foreign doctors, some of whom stay for anywhere from 1 to 3 months. And this is enormously important because these doctors, say from sub-Saharan Africa, from Southeast Asia, are learning this manual small incision technique, as well as phaco, and learning the Yerevan system. to try to bring that back home. So here again, you're going to see he's going to place the lens, and this whole case, you can tell, is basically done in 3 minutes. And it's amazing how efficient they are and cost effective. And then you see the patient alongside is getting ready. So for those of us that do all we can to have a fast turnover, we can only dream of this kind of volume. So the latest hospital is this one in Chennai, and this is the largest of the Aravind systems. And the woman that you saw, Dr. Haripriya, runs this. So that's lesson number 1. And lesson number 2 is that this technique is probably something all of us could practice and get better results with our most advanced cataracts. Dr. Venkatesh and I have published some of the things on this, and I had some firsthand experience with this in 2005. I did a study with Jeff Tabin and Sandik Ruit in Nepal. We did a randomized trial where at a cataract camp, the patients were randomized. Here you can see that 1 out of 4 was blind with mature cataract. They were randomized to having either phaco done by me with the Western equipment, a Western phaco machine, or this manual small incision method by the Nepalese master, Dr. Ruit. And you can see that the complication rates were about comparable. I was really, really nervous because these were such advanced cataracts, and all I could think about was having, David Chang with a 30% capsule rupture rate published and immortalized in the literature. I had one case of PC rupture. It took me 45 minutes to handle, and I barely finished the number of cases that we had to do. In short, I had more corneal edema. These were ultrabrunescent cataracts, but they did clear. We didn't lose any corneas. And if you look at uncorrected acuity, which is in developing countries, frequently, patients aren't going to wear glasses. They're not driving. It was pretty darn comparable. 20/60 is the WHO sort of definition of functional vision. So that's at 6 months, and this is at a year between the group. So uncorrected acuity was pretty comparable, and that's because this temporal shelved incision doesn't induce astigmatism. And if you look at BCVA, there was no difference at 6 months. And at a year, the phaco patients that I did were a little bit better than Dr. Ruit's in terms of, acuity BCVA. And that's because we're starting to get PCO because he's using a PMMA lens with a rounded edge, and I had my Rexus with a square edge foldable PC IOL. So, but we found enormous differences in terms of cost per case and the OR time with comparable acuity at 3 weeks. And, we said the safety was similar, but I can tell you most of us would have, a higher complication rate doing phaco than manual small incision with these cases with poor corneal visibility. Dr. Haripriya and I then did a much larger study using the Madurai flagship hospital, comparing the safety rate of phaco and manual small incision. And this was just a 12-month period in 2009, 80,000 cases. That would take 15 years at many of our institutions. This is 1 year at one hospital. We looked at reoperations and ophthalmitis, and then looked at the difference between trainees and experienced surgeons. And they have their equivalent of the IRIS registry, which they've had now for more than a decade. This is their own EHR. And so you can go in and get all sorts of data here. So you can see that out of these 80,000, the complication rate was pretty comparable between phaco and manual small incision. But if you look at the trainees, okay, so over here, this is the staff, complication rates, phaco in purple, pretty comparable. But the fellows had higher complications with phaco, the residents even higher. And these visitors, remember, from foreign countries such as Africa, had really much higher rates of complications with phaco. And so this was very obvious. So we felt that with experience, both techniques worked well, but inexperienced surgeons or those that don't do a high volume were going to get a much higher complication rate with phaco using these very large numbers. So what do? When I face a case like this, I still have a handful of cases every year where I use my manual small incision. I make a scleral pocket. Here I'm stretching the pupil after sphincterotomies with trypan blue. I do a can opener. I extend it. I express the nucleus. I do my INA. I put in a PMMA lens. And I use, because it's the US, I use a suture. I'm kind of a wimp, whereas they would leave this unsutured. These are eyes that they're just generally not worried about astigmatism when they come in with the cataract like that, and they get a rapid recovery and the cornea looks quite a bit better. Well, PCO, we talked about that from the other study. It's an inconvenience for us and our patients, but in developing countries, it's the second leading cause of impaired vision because so many patients don't get diagnosed, or even if they do, don't have access to a YAG capsulotomy. So Dr. Nishi, first did some of the seminal work. These are rabbit eyes, and you can see that with the PMMA lens, you can see the PCO behind it. And he kind of drew the conclusion that when you have a round edge to your lens, the lens epithelial cells can get behind the optic, whereas the square edge, such as with this Ascrs soft, cause a bend and block the migration of cells from the fornix behind the posterior capsule. And he repeated these studies using a square edge PMMA lens and found this was comparable to the Ascrs soft. And his rabbit studies were well known to us. So, I kind of told the people at Irvine, what do you do to prevent PCO? Why don't we try to put a square edge on the IOL? And we had some people from industry in the US help us with that and came up with a way to do this. The modification costs about $1. So this is a study that this is showing that square edge PMMA lens. And this was Dr. Haripriya's patients. And what she did is took bilateral eyes of 50 patients, put a round edge and a square edge PMMA IOL, one in each eye. She actually did another group of 50 patients where we did an Ascrs soft in one eye and a square edge PMMA IOL in the other, and then did photographic serial photographs to look at PCO scores over time. So what you'll see here is surrounded by green is that square edge PMMA IOL. Takes an extra $1 to make this. And when you compare it to a round edge PMMA IOL or a square edge acrylic IOL, so these are two patients, just their two eyes followed over time, you can see the inhibition of PCO. Now we followed a lot of these patients for 9 years. This is very unusual to have this kind of follow-up. And that's what I'm going to show you here. So the square edge PMMA IOL is in blue. The PCO score on the left is rising. And you can see with the round edge, there's much higher PCO at 5 years. And when you go out further to 9 years, it keeps going up, which suggests that it's just a matter of time before people with a round edge PMMA IOL are going to get PCO. So compare that to the Ascrs soft. The Ascrs soft was still even higher. And we think that that's because it wasn't a continuous square edge all around the edges. So this was pretty impressive to look at a 9-year rate. And so as a result, all of the lenses that are PMMA now at Irvine are square edge, and they supply an enormous amount of these low-cost PMMA IOLs to other low to middle income countries internationally, and they're all now made with a square edge. All right, lesson number 4 is that intracameral moxifloxacin prophylaxis is safe and effective. Believe it or not, it's been 15 years since the ESCRS study on cefuroxime. And as I wrote in this invited editorial, the debate still continues because we don't have a commercially approved product in most of the world. So we undertook a study to look at their preparation of moxifloxacin. This was done at the Madurai Hospital and just the manual small incision. So you can see it's almost 80,000 patients in about a 1-year period again. And so the group that got the intracameral moxie had a 5-fold reduction in endophthalmitis. So here you can see the actual case numbers, 30 cases in the first half year, and then 6 cases in the second half, showing the benefit of the intracameral moxie. Now, they actually make this at Aura Lab, and it's approved in India for intraocular use. It's the same concentration as our Vigamox. Comes in this vial and it costs $1. I told you they reuse everything, so they can use this on anywhere to 5 to 6 patients. So it's basically 15 cents a dose. And you can see the drop in endophthalmitis rate. And so our conclusion was, if you're going to do things that would not be allowed in Western ORs because of concern of infection, well, it makes sense with this manual small incision, particularly if you have to work in a sort of outreach facility. Sometimes it's not even a hospital, to spend, $1 or less on an intracameral moxifloxacin. The results were so impressive to them with their monthly high volumes that then they immediately adopted this across the entire system. So we published data when we got to 300,000 before and after. And then the final iteration of this was when we had 1 million cases consecutive without, 1 million cases consecutive with intracameral moxie with the drop. This is a chart worth looking at because each of these bars is a 3-month period. And so the blue means without moxie, the orange means with, and I explained that there was a transition, so that during that 1-year period, there was both with and without. And what's amazing is just look at the volumes on each of these 3-month periods: 64,000 cases, 73,000 cases. So that's a 3-month period with enormous volume. And you could take any of the orange and any of the blue bars and compare them, and it's very statistically significant. So here we see those 2 million cases, the breakdown. The infection rate went from 7 per 10,000 down to 2 per 10,000. Now, that was true whether there's the 7 and there's the 2. That was true whether you looked at the manual small incision. There was a 3-fold reduction. With phaco, it was a 6-fold. And where is this 2 per 10,000 now comparing? Well, our data from the IRIS registry is 4 per 10,000. So they're getting rates that are as good as ours. The other thing we looked at was posterior capsule rupture because we had enough, almost 28,000 cases now. And let's just look at that for a moment. 28,000 consecutive cases of PC rupture. And these are the eyes without intracameral moxie. So their overall rate is about 1.5%, pretty comparable to other large published rates around the world. And you can see that the endophthalmitis rate is up 7-fold. You get a 7-fold increase when the capsule ruptures because now you have no barrier. What happens with moxie? Well, you still get an increase in PCR in endophthalmitis with PCR, but it's much lower than if you didn't use the moxifloxacin by about 1/2. So we also, this gave us a chance to look at uncomplicated cases, because if the PCR rate increases endophthalmitis significantly, what about uncomplicated cases? You can still see that with moxie, it really lowers endophthalmitis in uncomplicated cases as well. Phaco, for instance, you go from 6 per 10,000 down to 1 per 10,000 in these 300,000 eyes in each group. So this, to me, is sort of the best evidence right here, argument for intracameral moxie. 300,000 phacos with and 300 without, and you drop the rate by 6-fold, and this is excluding PCR. All right, so how is this influencing us? I led efforts in 2007 and 2014 to do the ASCRS clinical survey, and we just completed the one for 2021. It's actually published in the January issue this month of JCRS. And we had, again, 1,200 respondents, and let me just show you the results. Now, What's nice about these surveys, I use the exact same question in all 3 surveys, so the results, should be comparable. And you can see the rate of use of intracameral antibiotic has steadily risen to now 2 out of 3 of us. And most of us are directly injecting this, whereas back in 2007, it was half were putting it in the bottle. But the agent of choice now is by far and away moxifloxacin, 3 out of 4. Vancomycin has dropped to 6%. And if you go back just to the last survey, it was the #1 most common antibiotic chosen, especially if you look at just the United States. So it was by far and away the leader in the US. And of course, the reason that's fallen off is HORV. We also did this study at Aravind where we compared 0.1 ml of a lower or a higher concentration. And we found that there was no difference in endothelial cell loss, which says that then you should use the higher concentration, which is what they are doing. All right. So the final lesson is a very important one. And that is that many of the regulations that cause us to throw things out in the operating room are of unproven benefit, but are increasing our costs and our level of waste. So this is an article we wrote for the Royal College of Surgeons had a special issue of their bulletin devoted to planetary health. And we wrote this one again about learning from low to middle income countries on how to optimize resources, because they cannot afford to be wasteful since they have limited resources to begin with. And the point was that we could learn from them. A bit of history. In 2009, the Joint Commission decided that nobody should use flash sterilization. And they basically said, all the ophthalmology ASCs and centers, if you're not doing a full terminal wrap cycle, like you do at the end of the day on Friday, basically a 1-hour cooking, you can't operate. And this came out of the blue. And I was on a task force from the Academy and ASCRS. And we just made the case that, well, this is what we've been doing. And they said, well, show us where in the literature you have any documentation of what your endophthalmitis rate is. And we didn't have one. So I wrote to Dr. Venkatesh and Dr. Ravindran, and we quickly pulled out the case numbers at this Pondicherry Aravind, and we're able to show that, they're reusing all these things, but specifically using this short cycle sterilization without wrapping the instruments, a very quick cycle, and that the rate was low. And this paper was actually what convinced the Joint Commission to allow us to continue to do this short cycle sterilization. This continued to come up. It actually came up again in 2014 when CMS came out and said you can't do this short cycle. And similarly, we had to do studies to kind of defend it. So 2 times we successfully defended our use of rapid short cycle sterilization. And part of this, this was part of a large effort on many different fronts to sort of say that eye instruments are different from general surgical and orthopedic instruments. And so we led this effort, again, a joint effort from the Academy and Ascrs and US on specialty specific guidelines for the cleaning and sterilization of intraocular instruments. Now, some really important data has come out of Aravind. This is Cassie Teal. You see Dr. Venkatesh over here. And they've done this life cycle analysis to look at the carbon footprint of cataract surgery. And what they found is that it's much lower there than it is in the West. I was surprised to learn that 10% of carbon emissions in the US from the healthcare system, it's been a huge increase. We're double that of Canada and the UK, where it's about 5%. Most of this is from the OR and labor and delivery. And if you just extrapolate to the number of cataract surgeries that we're going to be doing in the future, you can quickly see that this level of waste is unsustainable, both from the carbon footprint and the financial burden. We already know how large a percentage of Medicare's budget just goes to cataract surgery alone. So this is an important area. And this is the work done at that Pondicherry Center. Basically, this is one cataract, the carbon footprint in the UK, a phaco, it's equivalent to driving a car 300 miles. Whereas one phaco now, not the manual small incision, this is phaco at Erevan, it's equivalent to driving a car 15 miles. It's a 20-fold change. And where is the difference coming from? A lot of it is equipment and pharmaceuticals, basically throwing everything out after you use it once. This is my OR, the waste after a typical day. This is 28 cases. This is 93 cases from one day at Erevan in comparison. You might say, well, when you reuse stuff, what about TAS? So we actually did a study of TAS at Erevan, and this included 2 outbreaks, and we found that the rate was still low, even though they're reusing everything, and that there was no situation where people lost vision from that. So when I was chair of the AAO Cataract PPP, and also in these guidelines that I just mentioned, tried to editorialize about the fact that we have to not just keep adding more and more regulations, kind of practicing defensive medicine. We really need to, ask for evidence, not just eminence in terms of new regulations. So this led us to this survey. It was done jointly again from this task force, the Academy, Ascrs, US, and the Canadian Ophthalmology Society. Cassie Teal and I wrote the questions and conducted it. And we had more than 1,300 people responding, more than 1,000 surgeons. 9 out of 10 are concerned about global warming, but pretty much unanimously, or a strong majority feeling that we are wasting a lot and we should look for ways to reduce our OR trash. 5% said no changes are needed. So just a couple of highlights, what are the main drivers of the waste? Single-use packaging. We've got our facilities and regulatory agencies limiting our discretion on what we can reuse. And then manufacturers mandating single use to limit liability or to drive us to more profitable products. Now, these are just different categories where respondents were asked, would you reuse or be willing to? So topical, intraocular, and supply items. So topical drugs, it turns out that most people are either already reusing them or would consider it using them from a multi-bottle. Well, that's a no-brainer. And here's intraocular, almost as high, willing to reuse on multiple patients or already using. And then more intraoculars. Turns out with compounded, again, most people aren't reusing them, but are willing to consider that. Again, following what is kind of being done at Erevan. And then this is just supply items like the phaco and INA tips, the tubing, and even needles. Supply items, cannulas, blades, sutures. So the consensus here was that, yes, our colleagues are concerned about global warming. Trash is excessive. We all want more options, perhaps reusable or multi-use. If given a choice between a reusable and a disposable instrument that were of equal cost, 10 times as many people would prefer the reusable one. And then discretion to reuse and manufacture consideration of carbon footprint. So this was the survey on the left that was published, and then I was invited to write this editorial when after that survey came out in ophthalmology on needless waste. And I basically put these 2 studies alongside each other. First, the Cassie Teal study that said, our carbon footprint in terms of largely due to waste of drugs and supplies is 20 times higher for one phaco. And yet our infection rate is no lower. In fact, it's a little higher if you compare what we get from the IRIS registry. So when you put that together, what does it say? Well, we are wasting a lot that has really, and there's really no proven benefit for throwing things out every time we use them. This is a study that just came out online this week from the British Journal, and this is a study that we conducted during COVID when it first happened in 2020. You'll recall that everything shut down, and so when they reopened at Yerevan, they kind of followed the Indian Society national guidelines. And so prior, their normal thing was just let people wear their own clothes, the OR. Here, they put everybody into scrub gowns. I showed you that they might have multiple patients in the OR at a time. Well, they only had one at a time, right? What if the patient was COVID positive? We were all being so careful. And they never changed gloves in between cases before, but this time everybody would change gloves in between every case. And you can see that during these time periods, we still had a large number of people at this, one hospital. And this is the infection rate. It was the same. So the idea was basically, if we adopt all these standards and protocols that are used in the West, would that actually reduce the infection rate? And we could not find a change here. So, at least adding a little more data to this argument. So to summarize, I'm just so fortunate, I think, to have had this relationship with Yerevan. I just want to share some of these lessons that manual small incision is much more affordable and scalable. It's very comparable to phaco for surgeons that are not highly experienced at phaco. And because it's scalable and affordable, it's a great solution for global cataract blindness. But I think we would all, if we knew this, would have better results if we selectively use this manual small incision on some of our most difficult cases instead of trying to do phaco on everyone. We talked about PCO rate and how the square edge, it's not the material, it's a square edge that reduces PCO. And I think this has given us the strongest data on moxifloxacin. And even if you aren't convinced you need it routinely, if you do break the capsule, please consider that. And then finally, this very important lesson that we really should reevaluate a lot of what we're doing in terms of what evidence is there that it makes any difference. So I just want to end by circling back to Dr. Venkataswamy. This is one man's vision to found the Yerevan eye care system. And it's really an amazing group of people. And this is, I owe a lot to them, and I've just thoroughly enjoyed the 19 years now that we've collaborated on many things. But as Dr. Venkataswamy would always tell people, don't rest. There's still plenty to be done as long as there's a lot of global blindness. So I again want to thank the Society. This is such a wonderful honor, and thank you again for the time today.